recording of this. Yes, Busoga Health Forum is an association of like-minded people and professions stimulating community government partner actions for better health of our people. The word health, it goes beyond medical and deformities, but also goes to economic and social well-being of our individuals. That's why we are here as a firm. We are national and not-for-profit voluntary membership organization, and our headquarters are here in Jinja. BHF, we work in collaboration with the Ministry of Health. We work with local government institutions. We work with civil society organization, and this is all aimed to coordinate health interventions through our established technical working groups. And you, as who is on this call, you are all invited to be part of these technical working groups just because you work through our members. We work with district health teams, and that's why our DHOs are always a representation of Busoga Health Forum. But we also work with the formal and non-formal community structures because they are also part of our community. BHF is therefore a think tank generating evidence to drive policy actions to improve the health and development of individuals who are living in Busoga and beyond. As an organization, our vision is a health thriving Busoga. As brief as it is very rich. Just when we start dissecting the word health and then thriving, that's why we work through our mission. We want to achieve that vision. And our mission is to help professionals to use evidence to engage community, government, and partner actions for better health of children, youth, women, and men in Busoga. This covers every person. You are either a child, you are youth, you are a woman, you are a man. That will reach you. And just as another beautiful organization, our core values are value addition, collaboration, and integration. Impact focus. If anything doesn't make impact, how would we go for it? Transparency and accountability, effectiveness. These are some of our core program areas, but we also do beyond this. These are just core ones that almost when we are doing any program, it must follow or address one of them. And the first one being RAMNAC, that's reproductive, maternal, newborn, child, and adolescent health. We have malaria, HIV, and TB. Regional planning and data use, that's very crucial. Infectious and non-communicable diseases, these are around and on increase. That's why we have addressed non-communicable diseases and also infectious diseases. But urban health, because of the development that's coming, interventions addressing changes that are brought about by urban health. You can reach to Busoga from through our website. It's very rich. Please feel free to get some of the resources, recordings of such sessions, but also if you're doing any research, we have many papers published policy on our website. You can follow us through on our Twitter handle, Facebook, YouTube contains the recordings of such sessions, but also other good other interventions we are doing in that area. You can write to Busoga Health Forum for any inquiry, use that email, that's our official email. Not forgetting we membership organization and we work through members. Members through the membership subscription, we are able to continue with such activities like the Zoom session that's happening now. That's why I'll never stop encouraging members to register and become HF members, such that you make a contribution to Busoga Health Forum. Your contribution supports activities like EAT activities, the ACD outreaches. We are having the income. I want to acknowledge that part of the membership subscription is going to support the activities on the royal wedding, which is happening on 15th to 17th of this month. Pray the wedding should be on 15th. But we are also encouraging if you come to vote here, there's some people are requested to join. Inbox me and we will give an idea about community. Thank you so much. That's about Busoga Health Forum that organized the CME. Now I want to tell you about our presenter for today, Ms. Anna. Anna Columna is the director of Kyabirwa Surgical Centre. Am I the members? Okay. Yeah, Miss Anna Rumanya holds a bachelor's in mass communication from Busoga University, a graduate diploma in management studies from Uganda Management Institute, and master's in health service management from International University. He is currently the director of the Global Surgical Initiative, a Kyabirwa Surgical Centre, a charitable hospital started by Eric Mount Sinai Hospital located in Kyabirwa, India. Anna has vast experience in management of health service, having spent a large time of her career in administration with international medical groups. That's also international hospital before visited the medical insurance department of East Africa and underwriter, now Liberty Heritage Uganda. Prior to this, Anna was the managing director of the Heritage Limited, petroleum implement and distribution in Uganda. Also headed a public relations communication office at Uganda, the country's hydroelectricity producer. Under Anna's leadership, Kyabirwa Surgical Centre stands out for its innovative approach, using advanced technology to enable local surgeons to receive machines from US experts, excelling in respiratory and related fields. Anna has always been academically, most recently being a published paper, acceptability
Excuse
of
me, speaker. Hello. I don't know whether it's on my side, but your communication is breaking.
I
It's everywhere. Even I think it is his speaker.
Okay, am I able?
They are not yet clear.
Not clear.
Hello. Okay,
We are
I'm
getting
using
it
another
now.
microphone.
It's fine.
Do you now hear me?
Yeah, now
Yeah, we can hear.
Okay. I'll just be excused and I repeat Anna's bio such that we can understand the person who is going to present to us. Anna Tramanya holds a bachelor's in mass communication from Makerere University, a postgraduate diploma in management studies from Uganda Management Institute, and a master's in health service management from Busoga International University. She is currently the director of the Global Surgical Initiative Kyabirwa Surgical Centre, a charitable hospital started by Americans Mount Sinai Hospital and located in Kyabirwa, a rural village in Jinja. Anna has vast experience in management of health service, having spent a large time of her career in administration with International Medical Group, also known as International Hospital. Before leaving to set up the Medical Insurance Department of East Africa, underwriters now Liberty Health Uganda. Prior to this, Anne was the managing director of Red Concepts Limited, a petroleum importation and distribution entity in Uganda. She also headed the Public Relations and Communication Office at Eskom Uganda, the country's hydroelectricity producer. Under Anne's leadership, Kyabirwa Surgical Centre stands out for its innovative approach using advanced technology to enable local surgeons receive mentorship from US experts, excelling in telesurgery and related fields. Anna has also contributed academically, most recently being her published paper on acceptability of ambulatory surgical services from its predictors among residents of Budondo sub-county, that's in Jinja district in Uganda. Anna is married, a mother of 4, and a devout Christian. Right now, members, allow me have Anna make her presentation to us with her experience in managing a rural surgical center. Thank you so much.
Thank you very much, Benjamin. Benjamin is moderating all the way from Nairobi. Since the moderator couldn't attend, she got a personal problem. But thank you, Benjamin. I think you've done a good job, and I'll go straight into my presentation. I'm sharing my screen right now. I hope you can see my screen, dear audience. Can you see it? Can someone confirm that my screen is visible right now? I'm sharing.
Yes,
Yes, it is visible.
Thank you very much. Again, thank you, dear viewers, for sparing your time to come and join in as we share. I share the experience that we have at Kyabirwa Surgical Centre in managing a rural-based hospital. My name's already introduced as Anna Turumanya Kalumuna, and I work as the director of Kyabirwa Surgical Centre. This is a brief of the considerations we'll go through during this presentation. I won't go through them, but I tried to isolate all the important aspects that we need to consider or remember in the management of a center, a rural center. Briefly, to talk about Kyabirwa Surgical Centre, which is our case model. The picture on the right is how it looks like, probably a little more developed than that right now. The other, but that's an overall picture of how the center looks like. It's an ambulatory surgical center. Ambulatory simply means it's a day case surgical center. All the patients are sent home. It's located in Kyabirwa, Budondo, Eastern Uganda. For those who are familiar with the former tourist attraction Bujagali Falls, it's just a stone throw away from there. It was founded in September 2019. It was founded by a renowned American hospital called Mount Sinai Hospital. That's based in New York. There's a chain of hospitals in New York under Mount Sinai. It is a charitable organization, so this might bias the presentation a little, since it's not profit-making. It's charitable, and it's a non-government organization. And just for the record, to show our record so far, as of yesterday, when I completed this, we have done over 4,420 surgeries to date. Now, before we go into any details of managing a hospital, the most important consideration is the philosophy, which is really how distinctively we work. And that's a quote from Sheila Margolis, who is a scholar in strategic organization management. So our vision at Kyabirwa is to be a center for excellent, affordable, safe ambulatory surgical care in Uganda. It's that precise. And so to get that, our mission is to break the barriers to surgical care by providing safe, affordable ambulatory surgery, which obviously favorably impacts the global health crisis. And lastly, we follow those values. We make sure we are teachable. Everybody who comes on board must be able to learn something else. We strive to be excellent at what we do. We make sure that our services are affordable. Like I said, we are charitable. We center our patients in all our decision making. And lastly, we pride in healthcare innovation. To describe the business model that we follow, I borrowed a renowned model called the Pestel model from a former Harvard professor called Francis Aguilar, to sort of give a layout of what our strategic management looks like, or our strategic model. Like I said, politically, we are a non-government organization. We try to be non-partisan. Our economic considerations is we stratify our patients. We target especially the vulnerable community. So we must know, their economic activities, their sources of income. We know their lifestyle and how our surgeries or our work impacts their lifestyle. There are considerations on the, sanitation, since it's surgery and we are very wary of attentive to infection control. This helps us also mind the pricing. Who do we waive off completely? Who can't pay a penny? Like I said, because we are an ambulatory center, we are not for profit. We target the vulnerable patients. In fact, the highest charge we ever make on any of our patients is about 28% of cost. So that's the highest that we charge. We have social cultural considerations. Of course, there's so many beliefs about surgery. As you can imagine, people believe surgery is a no-go zone. So we try to demystify those in whatever we do. We are considerate of education levels of our clients, patients. So we make sure that we understand them so that we serve them very well. We consider things like effect on, if we're doing surgery, what's the effect on their religious beliefs, gender. So we do community sensitizations, we do media campaigns and the like in a bid to understand our business model in terms of social cultural factors. Technologically, is a very big aspect as well in our model. We use an EMR, an electronic medical records called Clinic Master. We are very keen on the communication channels we must use for our patients. So we ensure that they should be able to understand what we're communication. We also consider our other health service providers that refer to us patients, even our staff that we recruit. Are they tech savvy? How can we help them get there? One of the biggest challenges we have faced just off the presentation is that our X-ray, because we try to promote environmental sustainability, we do not print our X-rays on the renowned plastic prints, because as you can imagine, they would be damaging to the environment. The Western world, the developed countries have moved on from that. So we're trying to break the stereotype that it has to be plastic. And so it's important for us to understand the people we work with and how do we support them to move with us in our business strategy. Environmental factors, of course, we considerations like infrastructure, road challenges. We are located in a rural area, so what's the impact of that in our surgical care as our patients travel back home? How about common amenities like water? Are they able to be able to mind their sanitation post-surgery, waste management, and the like? Then, of course, lastly, in the model, the legal considerations, we are registered. We are both registered as an international and a local NGO. We were incorporated locally, and also we have all the regulation, licensing, and we work with the Ministry of Health. So when we start digging into the management of our rural center, I thought we should have an idea of the top, 5, 4, 6 capital requirements. The pie chart shows exactly that. Like I just picked out a few. Of course, there are several other. But as you can see, top on the list is the medical equipment. That's the 55%. I hope it's visible. Then the assets, the buildings. Many people think land and buildings are the highest, but from my experience, medical equipment is the highest. So we have land, we have solar, we have water, we have internet, dedicated internet. We run a fiber cable for that. Of course, there are things like vehicles that are also high up there, acquiring as well as maintenance. We need an ambulance because, of course, we're into surgery. We need a van. We are located in rural areas, so we need to figure a way of transporting. Then, of course, we have a program that requires motorbikes that I'll elaborate later on. Amongst the capital requirements, of course, is the working capital along the way. For us right now, 85% is reliant on donations, where 15% is what we collect, but that model is slowly growing bigger. Yeah, equipment, like I said, medical and IT. We have 2 operation theaters. We have a space where the patients recover from, and then we have diagnostics as well as other IT equipment. This picture is just to show you that the tanks on the left are underground tanks currently to a capacity of 150,000 liters. That's enough water for the whole region. We have on the right our solar model. The panels is the roof of the center. The middle picture are the batteries. We've boosted those up now, and as well as the lower part are the inverters, which basically gives us a capacity altogether of 30,000 kilowatt. We're improving it to now 120 in our expansion program. We'll start with human capital as one of the big areas in management of a rural center that we must think of. Management structures ought to be clear. For the sake of Kyabirwa, on the right, I gave a brief idea of how we run. We have a hierarchy. There's a board, there's the directors and senior management team splitting down into clinical directorate and then the non-clinical directorate. Of course, in there are the different departments, clinical with direct interaction with the patients, while non-clinical supporting all the other functions. So ours is a hierarchical kind of approach, but giving a level of accountability to every department. We track performance for every department, and we give departments a degree of autonomy so that when they put in place their standard operating procedures and we think they are good to go, we empower them with the capability to implement them. And the rest of the management role is to make sure that we keep on track of our goals. Of course, human resource, like everybody should know by now, is the most valued asset. And for us at Kyabirwa, it's the biggest cost center. It's over closing into 60% of our cost as the center. We have to make sure they are happy. So we have structured, clear recruitment processes. One of them, for example, for us is we give back to our community. We say that all the non-professionals must come from the community. So all our housekeeping, the maintenance team, the drivers, the support team come from the community, but we don't compromise on the professionals. So we do an open recruitment, and the most competitive candidate takes the role. Then we have vigorous and innovative HR retention policies that are mindful of both the intrinsic and extrinsic features. So we don't just dwell on salary and all. We also try to offer all other holistic support, because as a rural center, we want to have a motivated workforce. Right now, our workforce is most of them range between late 20s and early 30s, actually from mid 20s to early 30s. And so it's a very vibrant team that you want to make sure is happy, is motivated, and can stick with you even when you're located in a place as rural as ours. So among the things we do for them, we make sure our staff is well trained continuously. We provide healthcare to the best that we can. We nurture relationships beyond just the routine work. We have a lot of after work engagements to make sure people are happy. Of course, we feed them. Food is critical. We also do appraisals so that they know how they are faring. We track their progresses and basically make sure that we keep a very motivated workforce. The next aspect there is the patient management, and I categorized that into 3 aspects: the pre-surgery or pre-hospital management, then while at hospital, which is the intra-hospital, and lastly, the post-operative management. We're going to look at how we manage all these in our center. So for the pre-hospital surgery, we have management. We have a primary healthcare program. We discovered when we began that there were a lot of misinformation out there about surgery. And also that people in the community prefer seeking healthcare intervention in late stages when it is too late to help them. So we realize that we cannot disentangle ourselves from primary healthcare. So we do a lot of prevention and promotion in the communities. We do community sensitizations. The pictures on the right are showing exactly that. We also actually have a mobile clinic out there. We want to make it comfortable for our patients because one of the biggest issue is cost. And when we talk of cost, even transport is an issue. So if we can meet them in the communities and be able to recruit them or sensitize them and save them the transport cost, we will do that. We do a lot of pre-surgery education so that whoever comes in for surgery is well informed and consents very well. We have a detailed patient selection criteria. We are very critical on that because our model is ambulatory. We acknowledge that we cannot do every surgery under the sun, but we know that our contribution is big. It's in the range of about 75% or slightly more in the surgical conditions. So we can handle about 75% of them. And so we have a very good selection process criteria. And then we have a common e-patient booking platform. Any of our clinical staff who are concerned with this process are able to see which patients we've booked, where do they come from, what do we need to do to make sure they are all prepared so that we all have a shared control and a smart mechanism, as well as a psychosocial support system. Many of our patients book surgery or we talk to them, but then they get scared at the last minute. Many of them after surgery, there's a lot of changes in their lifestyle. So we have a psychosocial support system using our social workers. Intra-hospital, here is when the patients, from the moment they arrive, we make sure that there's an efficient and clear patient preparation protocol system through our protocol. We make sure that it's clear how we line up our patients. We will not get a patient who's going to get a hysterectomy, for example, start surgery at 4 p.m. when we're closing. So we make sure we are clear on how we manage the business in that time. So in other words, the patients that require longer recovery time will start with those ones. Then we make sure we start early because some conditions require a little longer recovery than others. So we have to adhere to time management. We're very strict on time management. When we start turnaround time, which is the time from when the last patient is operated to when the next patient is wheeled into the OR, we monitor and track that information because we want to make sure that our patients are comfortable and ready to go home in the right time. Then our protocol dictates that by 5 p.m. we should be closing business. So in whatever, and we don't close business haphazardly. We must have finished our patients. They must be stable. They should be feeding. If the protocol allows, they should be mobile and ready to travel back home and comfortable. And then we follow them at home, which is the post-surgery care. We have on the right, that's an app that we keep. Actually, I took that screenshot today. This app is really about post-surgery care. And so if you see that there is this, the nurse whom I took this from he's called Herbert Mazinga. Herbert allowed me to show this. And basically today it was telling him that he has one post-operation patient that he needs to follow up on. He has, for day 1, he has 4. For day 3, he has, from day 7 to day 10, he has 7, like that. So we have this app that helps us follow our patients. So we then hit the community. And on the left, you see one of our very jolly nurses, Jotham, who's one of our recovery at home nurses, following up on the patient, using the app to document the recovery parameters of this patient. And in that real time, if there's any information that he captures that is reason to worry, the doctor back at the center will get a notification right away on the same app that will tell him Jotham is seeing a patient. He has entered the following information. When we tally it in our logarithm, we see that this is a patient maybe who's at risk. What can we do to rescue them, or how do you advise to go forward? So the doctors will call the field nurses and follow up. The purpose of this is to ease the patient's recovery process, empower them to recover at home, but work with them on this, make sure they are adhering to the instructions, and also save them the transport of having to commute back and forth to the hospital, and basically give them a peaceful recovery post-surgery. I wanted to touch a bit on our supply chain and procurement, because everybody asks about that. Given that we are in the rural area, far away from the good suppliers, one of the most important things for us is supplier relationship management. We communicate what our vision is to these people. So when we're negotiating prices, we make sure that that's a consideration, that we're not making any profits out of this. In fact, all our surgical patients will take medication without any cost on it. We won't charge them for that. We make sure we use tried and tested suppliers, and that is how we have maintained a less than 3% infection rate post-operatively, because of course our model is new in terms of sending all the patients home and not hospitalizing. So we are careful not to raise infection. So we must make sure that drugs are reliable. We have a good donor relationship with several suppliers like Johnson & Johnson, who have given us sutures that can, take us for the several years, and several others. So we try to promote those relationships so that we support the patients affordably. We do sometimes have to import certain supplies. There are a lot of medical supplies that are not reliable on the market. Stents are an example of them. So we have also that option. We try to make sure we get long expiries, because of course in a community like ours in the rural area, we don't want to have back and forth engagements with suppliers, but also we emphasize to our suppliers that they have to be flexible. Like I said, we are best in the village, in the very remote area. Accessibility is not so straightforward. So if a supplier is not ready to be as flexible, then it becomes a problem. So, but that is handled through relationship management. We have a marketing strategy, of course. On the right there is Dr. Angelica on a Masuze Mutia talk show. So we engage our stakeholders, and we have collaborative forums that we attend to. CMEs like this one, Busoga Health Forum, we are members, and it's been supportive in achieving this. We maintain good media relations. We do a lot of radio talk shows, TV shows, because awareness is key. Like I said, as a rural center, it's important to make sure we meet our targets or our vision by making sure people know about us. So we get involved in community activities. We do camps. Many times we tell our patients that this month we won't charge you anything, come and we treat you from the community, so that we try and give back to them. We do a lot of educative literature circulation, flyers and all that. Social media presence, we are on Twitter, we are on Facebook, we are on Instagram and all that media. We have a website, Kyabirwa-SC.com, and then we also have friendly interactions. We do football matches. So in other words, what I'm trying to put forward here is, in managing a rural center, making sure that your presence, your marketing strategies and your public relation game is very important in making sure that your presence is felt and your vision is fulfilled. Everybody asks about quality assurance, monitoring and evaluation. These are some of the things that we do to make sure we are agile in that area. Daily, the first thing we do every morning is a quality assurance meeting, and every staff should be in it. In this meeting, we report how many patients we received yesterday, how many of those were surgery, how many did we refer, how many, how long did our patients take at triage, how long did they take in radiology, what was the turnaround time in theater, why did we start late, which computers broke down. It's a quick, brief 15 minutes meeting, but very key in making sure that we are up on our game on a daily basis in terms of quality, because right there, any issues lagging behind are picked. We also have, of course, we follow the surgical checklist that is mandatory to just make sure that our certain areas are not compromised. On a monthly, every department must meet. Quarterly, we have clinical meetings, we have mortality and morbidity meetings. They help us review, errors that we've made, lessons that we need to learn. The quality assurance, on the side of the laboratory, we have quality assurance that is done on a quarterly basis. Others, and very key here, is research. We have a very big research department. To date, we have published in journals, abstracts, and scientific presentations over 20 papers in different subjects. We have over 30 papers coming up because we feel we have a unique story to tell. So our research department is very critical. So every day there is research ongoing at Kyabirwa and data being captured. We have staff mentorship programs. All our doctors must go through some superior mentorship, right from the chief surgeon to the junior medical officers. But even then, even internally, the chief surgeon must mentor the lower one. So we try to promote that degree of mentorship. We have annual internal audits, external audit, of course, and then collaborations, which I'm going to talk about a little more. So we feel that in evaluating our performance and ensuring our quality is progressing, is up there, there are some of these collaborations contribute to that. Mount Sinai, in particular, who are our founders, we have an exchange program. We send their people every now and then to visit, benchmark, learn what to do differently. But they also send us their students, medical students, even residents. Right now we have residents around who come and we share ideas. We learn from them, they learn from us, and we keep improving, which helps us in improvement. We have a partnership with Busitema University for mentoring, teaching their anesthesia students. They rotate at the center. Busoga Hospital sends us nurses also on rotation. We work with Jinja Regional Referral Hospital for CMEs. We also engage them in training for endoscopy. We are working with COSEXA to get accreditation. I hope there's a COSEXA member in the leadership somewhere in the audience. But yes, we're working on that because then we'll be able to train our COSEXA students at our center and they'll get accreditation. Then we have training in laparoscopy surgery. And this is done remotely. To get certification on fundamentals for laparoscopic surgery. Then also we do collaborate with Busoga Health Forum. This is last but not least. And they help us open us to audiences where we can collaborate and improve what we do. Briefly, I'll tell you about challenges in managing our facility, our hospital. One of them, and top up there, is acceptability. Like I said, this is a unique model. There's still a lot of wrong misinformation about surgery. So there's a lot of delayed health-seeking behavior. And right now, we're actually working on a paper to find out about acceptability, even among the health workers. Do they agree with this model of treat patients, operate them, and send them home? So some of you esteemed doctors and health workers on this forum will be coming to you in this research. Accessibility, of course, the road network. This is a typical picture of our nurse in the community trying to visit a patient, and the road couldn't let him travel peacefully. But also, sometimes there are delays in support, or if you need some service providers, there can be a delay because of that. Scarcity of some supplies. I gave an example of stents. Affordability, even when we are heavily subsidized with a consultation fee of 8,000 for a surgeon, there are still people who can't afford 8,000. So it's still a problem, and a lot of it they can't afford, but a lot of it is health prioritization. As we all know, many people would rather hold a smartphone but not willingly pay a certain fee to get their hernia treated or to get their thyroid removed. Employee retention, like I said, it's a young, vibrant group. This is a list of our worries, to be honest, but it is a challenge, definitely. The fact that we are located in remotely, the fact that there's a lot of opportunities for health professionals, so sometimes there's a bit of nomadism, which given our program where we train, where we teach, can become a constraint. You know, you train somebody and then you lose them is not something we want to face. Then, of course, sometimes we feel that regulation can really have a weigh on us heavily. Occasionally, we get taxed for some of the training equipment that we bring in, and we're trying to work on that to make sure that that relationship improves. I'll briefly talk about, growth, our growth strategy, which also covers the sustainability and, the strategic plan. Of course, at the top end is that vision: quality, affordable, excellent surgical care. And so in 2023, we were focusing on surgeon and anesthesia sustainability training programs, seeing whom to partner with. We have a mentorship with philanthropists, a mentorship program. We have doctors who have done what we do for the last 20, 30 years and are happy to give us time every day to mentor our own doctors. And so we were strengthening that program. We were also making sure that we understand the scope of our services and which procedures can we expand into. We have currently completing expansion program we've been constructing, so we are able to expand on the base of services that we can do. Of course, developing a financial sustainability model. We have a whole department concerned with this to make sure that 10 years from now, Kyabirwa doesn't have to depend on donors. When we started, it was 100% donor. We have now been slowly chipping in a little to 85%. We are initiating surgical simulation training. We have a very good simulation lab coming in. It will be launched early next year. This lab has potential to train doctors, nurses, anesthesia providers, and other practitioners by giving them a simulation environment so that they have a sort of hands-on feeling of practices in their different disciplines. So we are initiating that program. We're also expanding the laboratory, allowing for broader testing and pathology. In 2025, we are setting up genetics and genomics banking. We have started already in setting up that lab. We also want to expand the program. We want to duplicate it in other areas and be able to run sustainably that way. So there is a plan to build 2-3 sites in future, and 2025 is when we want to embark on this program. So as a center, that is the strategic plan we are looking at. Precisely, this is the end of my presentation. I tried to touch a little bit of everything that's involved in management of the center, and of course, I think somebody needs to mute Christopher. I think Christopher needs to help us unmute. Yeah, so in brief, that is what I had to present for the time. And I am happy to take questions and any other issues or additions that you'd like to make. So Benjamin, I think we can take any questions right now. Thank you.
Yeah, thank you so much, Anne. This has been a wonderful presentation, very elaborate. It's an excellent story. It's quite inspiring for people to hear about Kyabirwa Surgical Centre. This is real and it's happening right here on the land of Jinja. And just not only the presentation, but we can also visit and have a physical learning at the center. Right now, I would ask for any people who would want to ask questions, and you'll have the answer right from Anne, who has seen this story grow from start up to here. Going through the chat, people are just thanking you and are happy about the presentation from all the comments I'm seeing. Then one person who is asking for the CPD link, it has been shared. But if you have any other questions on CPDs, please kindly, you can inbox me. Right now, I will take a few hands. If you are willing to ask a question, you can raise up your hand. Then you could make a comment or ask a question. Thank you. Yes, Vincent Ibwete, you can unmute and make your comment.
Yeah, thank you so much, Anne, and the moderator. This is quite an interesting model. What I wanted to understand more is if she how do they determine? I mean, who pays the 15% of the costs? 85% is donors. So where does the 15% come from? And what steps are they making? As she said, that they are trying to make sure that they become self-sustaining. What are the sources of funding they are looking at that will make them self-sustaining? And eventually, when we say 85%, is it 85% of the charge or 85% of the cost? At times, the cost may not necessarily be the same as the charge, because the cost has the space, has the human resource, has the utilities. So is it 85% of the total cost or 85% of the charge? Thank you so much.
Benjamin, I don't know if I should answer one at a time, or we take a number,
I want to take a number, then you could answer. I wanted to hear from Professor Peter, then Kasibante, then you could answer those ones. And yes, Professor Peter.
Thank you so much, my friend Anna Kalmuna. I see also Dr. Kalmuna in the chat. Long time. I mean, it is an amazing center. And perhaps, one of the greatest things we have burden is surgery. People in Busoga with a lot of surgical problems, hernias, a lot of deformities that we have, disabilities, etc. So I think it's great that we have you as an ambulatory surgical center. But Anna, I know that you are saying you are rural, but you are a few kilometers from Jinja. So is it, if you could discuss that a little bit more in terms of other centers, because I'm sure, for instance, this other surgical center, which is rural, the one that is run by Dr. Moveze, it's really quite more rural. Maybe it is, how many kilometers from Jinja? 40. And maybe you are 10 from Jinja. So maybe you have challenges, definitely. And I like some of the innovations, but I think you are not maybe as challenged as others. Then secondly, the question asked by Dr. Wet, I think is important, the issue of sustainability. We have so many struggling former missionary funded hospitals in the region. We have Kamudi, we have Buluba, and they actually struggle to maintain, especially the qualified staff. So if you could speak a little bit more about the sustainability model, is it really possible in these rural areas where people, or are you going to sustain it through research? Which brings me to the question around research. And for me, it is very exciting that you are going to genetic stuff. What is your motivation to go into genetic stuff? And finally, how can we collaborate with you? I come from Mackay University, from the School of Public Health. and we are not studying so much the public health of surgery. So how can we collaborate more with you? Thank you so much. But thank you, of course, for being members of Busoga Health Forum. We are so proud of you. As I speak, I'm actually seated in Boston and telling these people from Busoga here, so thank you so much.
Yeah, thank you so much, Prof. For that international insight. You should tell them that we are doing wonders in Uganda. Let me have Kasibante Samuel, then we can have Anne respond to this.
Yes, thank you. Definitely, Anne gave a very wonderful presentation, with a lot of clarity, and I think it looks into her kindness and the way he takes respects everyone. I visited her office. Probably a year plus ago, I was welcomed into the center. I really felt like coming back many more times. That said, and thanking her for the wonderful job of the leadership she's giving Kyabirwa, how does she manage to instill the practice of audits in a surgical center? Because compliance to standards is still a challenge in many of our facilities, and a facility that looks into itself internally and maybe also externally must be very serious with the services they offer the people and a pedigree of self-accountability. I want to know how Kyabirwa manages to prepare for the audits or to keep the documentation and making sure that scheduled audits are done. And then lastly, I wanted to ask Anna not personal, okay? What difference would she do if this wasn't a US-funded organization, but a government of Uganda funded facility? What other differences would the facility be doing to give a similar service she's offering now? Thank you.
Yeah, thank you so much, Samuel. And I think, Anne, you could take up those questions. When we come back, I'll be taking questions from the chat.
All right, thank you very much. First of all, thank you very much for the kind words, my friend, Professor Waiswa. Thank you that you logged in, and thank you for the compliments. Thank you very much. I will dig into the questions. Vincent asked about 15%, who pays the 15%. That statistic I was giving, out of 100% of our expenses for running the facility, 85% is funded by the donors, while 15% is funded by the patients. So 15% is the small charge that we put on them. Endoscopy services, for example, we charge 100,000. So that contribution that the patients make, consultation is 8,000. We have a small charge on each of our service, although, like I said, we have months when we don't charge anything for certain services. But on the day-to-day, there is a charge. So that's the percentage I was talking about. It's a 15% contribution. The question on sustainability, we look at it in various folds. First of all, how can the center run with very minimized costs? So before we go into the funding, we also want to make sure that we don't have a water bill. We don't have an electricity bill. Like I said, we run 100% on solar. Although there was a capital investment in that, for the next several years, in investment at all or expense in terms of power. So we have efficient power. There are things like internet, making sure that we work with organizations like Renew Research and Education Network that heavily subsidizes our internet because of the kind of work that we are doing, research and all. But also, trying to do so many, trying to minimize our costs through the economies of scale, making sure that at a certain point we keep our costs down but we increase on the number of patients. So whether a doctor does 1 surgery or does 20 surgeries in a day, as an example, maybe 20 is too high, but whether he does 1 or does 5, he will charge you the same for us. So trying to bring that degree of scalability, making sure that we keep our costs in a certain range is also important. In addition to that, in terms of sustainability, we are, of course, the co-payment is very minimal as well, but there are certain things that have that we do perfectly, or that we make emphasis on, that have attracted a lot of support. One of them is we are really data driven. And right now in the current world, things like data and things like renewable energy, green energy are what we are funding. There are so many projects that are happy to work with us if we can tell them how much electricity does every patient cost us, how much water does it take to do a hernia operation, how much, so our information management is very critical, and we have attracted a lot of funding in that direction in terms of partnership. In the developing world, as they answer the question of how do we advance healthcare, somebody needs to furnish this information. So through our accurate data management, we are able to sell. We have something to sell. We don't sell the data, but we sell the dynamics of the data that we generate. I don't know if that makes sense. The other investment that we are looking at is the lab, the genetics lab and genomics lab that is coming up. It's a very big investment and will be one of its kind in this region. And so we hope it will be doing a lot of research. Professor Waiswa, you pointed at that. Yes, we intend to do that as one of the investment arms of this center. Among others, we have other business paired ideas that have not yet fully rolled out, so maybe I can communicate at a later stage that are intended towards funding the center as well. But data, research, the lab, managed expenses, co-payment are all some of the areas that are helping us generate revenue. And with the paired business along the way, we should be able to shrink that percentage a lot more. You thought that Kyabirwa is not really rural. You should ask Benjamin why he called us rural, but I think to a certain extent we are rural, a large one. Our road network is, and unfortunately the definition of rural is relative. But whether is it the distance from amenities, or is it the lack of amenities in a certain area? But in this particular case, I think when Benjamin thought of us, he thought of the disadvantage we have in terms of the patients reaching where we work from, which is really the bad road network. Right now, Professor, if you came, you'd probably turn around at Amber Court and not reach there. That is an inconvenience for the patient. And
I'll end where your Tomaka stops.
Yes. Yeah, even basic things like water. Despite the fact that we're right next to the Nile, the river, we have a very huge water scarcity down there. And so in a day-to-day, we wouldn't get a reliable water supply to run our operations. Even basic, electricity, it's on and off and barely available, but lucky for us, we don't even notice when it's on because we are running majorly on solar. So I think the absence of basic amenities that support the running of a hospital makes us rural to a certain extent, distance notwithstanding. So basically the challenges rotate around that. They rotate around the fact that a nurse would rather work at Nile Hospital, where it is, right in the middle of town, than work at Kyabirwa, where she has to get dusty and struggle to get there. So those are some of the dynamics that make us more rural and, challenges. Our motivation in research, and I'm glad that you've pointed that out, is that we feel that what we are doing is unique. I think in Uganda we are possibly the only freestanding ambulatory center. There are several centers doing ambulatory surgery, but I think one that has adopted 100% ambulatory model could be just one of us and maybe one other that I'm not aware of. So that makes us unique, but there's a lot involved in that. So we track our outcomes. We want to tell the story. We might be boasting of ambulatory, but what is the post-operative infection rate? What procedures fall in that? Right now we do gynecology services. Our gynecologist does a total abdominal hysterectomy and sends the patient home. In the past, that is an area of contention. So her outcomes in that field are important to tell out there. Even an operation like a thyroidectomy, we know that in the past you would think that's a procedure that attracts admission. So now that we are breaking those stereotypes, now that we're causing a paradigm shift, don't we have the data that would help inform other policymakers? If our government can adopt this kind of strategy, perhaps the 5 billion gap of surgery scarcity, of inability to access surgery, would be bridged over a certain period of time. So our research is in all the areas that we are breaking ground for, that we are pioneering in, so that we have story to tell as we rally more service providers in our. Of course, in terms of public health, yes, we have a lot of interest in that, especially with some diseases that we are questioning whether they are lifestyle diseases or not. A common one being esophageal cancer, which like I've mentioned before, is quite on the rise in the area where we operate. So we are interested in knowing what are the disposal risk factors that are out there. What are we missing out on? And so the lab that we're going to develop is going to, how does genetics contribute to the Busoga hernia, for example? How does it contribute to the growing burden of esophageal cancer, and several other areas that we need to look into based on the diseases that we're discovering, based on the surgeries that
Hello, Anne.
And you're on mute.
Go back. You can now. You unmute your back.
Yes, I'm back. Yeah, sorry about that. Yeah, so basically to try and tell the story of what we are finding, what are the factors behind what we're finding, what can we contribute to the global burden in all these areas, and to tell the story. And we believe that that's a very virgin area for us, and we look forward to those strategic partnerships. Managing audit, as asked, is one of the things that has been helpful for us that I mentioned earlier is the fact that we try our best to benchmark Mount Sinai, whom we acknowledge the fact that they are a renowned world a hospital with proven standards that they have tried to keep, and so we try to follow, to pick up certain standards and try to insist on them. So for example, there are certain, all the departments have developed protocols that they must adhere to, and all the staff are kept and maintained according to performance. So everybody knows it, that it will matter the kind of data I captured for the patient when they were in recovery in my hands. If there is a gap in the patient data, it has a direct implication on my performance appraisal. And so we don't compromise on certain standards and on certain SOPs. Of course, one of the reasons is, like the topic, we are in a rural area. We want to minimize incidences as much as possible. We want to make sure that if we handle a patient and send them home, because we're sending them home every day, we want to make sure that they don't come back with a certain, infection arising from our negligence. So because of that, everybody has a certain degree of expectation that they know they are accountable to, and they must maintain. And it is a firm one, and, with consequences, of course, but lucky for us, given the nature of work we do, everybody is excited to make sure the targets are met and finished. But in terms of maintaining audit, we set protocols and we adhere to them. And it is the direct supervisor's responsibility to make sure that those are set and followed. And when we find issues, we deal with them as aggressively as we can to make sure there's no recurrence. What would we do differently if it was not a government facility, or if it was not if it was a government facility or not an American funded entity? I think, to be honest, we have capability to do what we do better in whichever setting we are at, but a lot of it has issues to do with compliance because of supervision, because of the whole laissez-faire attitude. We have set up systems where every staff comes in. The moment you come in, your presence is known because we pick your biometric fingerprint. Now, such an investment is not that big, but has a very big impact on someone's work ethic. If they know that every morning my fingerprint is the last to be clocked in, there's an implication. There are basic things like surveillance, basic things like making sure people know that they are being monitored, because we have a vision we are headed to. And if you keep pounding that philosophy I talked about into everybody's mind, everybody works towards it. So it ends up becoming a shared responsibility. At the end of the year, we know when we have saved any money, and therefore, by shrinking our costs, and therefore, can we enjoy it together? Can we have a package? Can we get a small increment? So everybody ends up knowing that it is my responsibility to contribute towards the success of the vision. So there are certain things, and I think on the other hand, maybe the government, some of the government facilities, there's a degree of, and maybe need to allow autonomy by, for example, my friend, Dr. Alfred, should be able to run his budget, should be able to run his with his team, because he's more familiar with the needs down here at Ginger Regional. He needs a degree of autonomy in managing the affairs of the hospital without having to fear the consequences at a certain level up there of somebody who will probably think you should not have done this or that. So a degree of allowing our leaders who are down on ground to implement and manage their processes adequately, and then monitor their performance, so that if we are to discredit them, we discredit them on merit, as opposed to breathing down their throat all the policies, all the, what they need to do, even when we know what they know what to do. So I think that helps for us in terms of making sure that the facility is different, and making sure that everybody stays on top of their game. And even when the top management is not there, the people down at the bottom know what's expected of them. And that is monitored on a daily in terms of expected output. I think, I don't know if I talked enough about documentation, and you asked about audit and documentation. Right now, as effective 1st of January, our target is we don't expect any inward paper in Kyabirwa. So all the paper we expect to have should be paper that has maybe come in from suppliers, in which we will reject, or a paper of discharge for our patient who is going home that we want them to read when they're there. But as far as we're concerned, we believe we can comfortably document all our systems, all our processes, and everything we do, including authorization, including audit, without having to print paper. And so if somebody understands that the information that we require has to be put somewhere. We have a system called the document management system, where every department has a library of their information that anybody can access if given rights. And like I said, in one of our funding structure is the fact that the information that we're creating a model that is replicable, and people are ready to buy the detail of how that model is set in terms of data comfortably. They are able to pay for that. So for us, documentation is really core. Data management is really core. And we document, like I said, I know how much water we consumed today. I know how much water power we consumed today. I know how much the solar plant released. There's an app tracking each of those things. We will know which patients are going to be followed on the app. We will also know which doctors we're going to collaborate with on the app. So we have a lot of data management that we do, and we've tried to automate our processes as much as possible so that we are able to follow through to the end. I don't know if I've answered you very well, but yeah, I think that's what you are looking at. Thank you.
Wow. Thank you so much, Anne. I believe we are almost coming to the end of this session. And I'll just request Professor Peter to give his comment, but also he will give the closing remarks to this session. Thank you, Prof.
Yeah, thank you so much, Anna. It's super exciting. I'm very proud of you guys and your work. And as an academic of public health focusing on leadership management, this is super impressive. And I want to make one request to you that especially in the management systems, you know, one time I challenged Chuoko Hospital. Chuoko Hospital, I've been advising them on many things. It is a center of excellence, especially newborn health. They've been doing work for about 30 years. They have outcomes similar to those of an issue in a developed country. But I told them, if you are so good, then scale up. So I like the fact that you are talking scale up. But I would like to, you don't have to answer, but I would like you to choose one or two things that you could collaborate with one of the hospitals in the region on the management systems, so that we see like transferability. I mean, because many people will always give the excuse, this is because this is a private center. This is why it can be done. But I think we need to demonstrate that these things can happen. Let's say, if we just start with the theater of Ginger Hospital, I wanted an online system for managing cesarean section, for instance, so that we're able to see the data and also outcomes. So just one component which you could run with a hospital, because I think that is the best way the government can learn from what you do, and then the impact becomes bigger. But I think you make some remarks after my closing remarks. As I said before, it is, and you can imagine I've been advertising this talk in the College of Health Sciences. I even send them a link to your center. Every time you present, I send to them, and there's a lot to learn from Kyabirwa. And the models are impressive. Surgery is known as one of the areas of highest burden of disease where we don't have models for meeting that burden. Imagine people living with a goiter, people living with a hernia for their life. It affects their productivity. And there is also a lot of stigma, and we need to find models of accessing that. So your model, we can work with you on so many things, like having students to cost the model, look at the cost effectiveness, do a policy analysis, and so many things that we can do. And from the Busoga Health Forum, of course, we are proud of you as one of our other collaborators. So thank you so much for being incredible. and let's take to scale. And when I visited a few months ago, 2 months ago, I said that when Busoga University opens, I think we shall model the medical school around Kyabirwa. So I think that is a great opportunity. And more, I look forward to visiting you once again. But with that, I would like to give this certificate of appreciation to Sister Anne Rose Baruka, one of also my good friends for a long time. Rose, please receive this again. We'd like to have more nurses to be exposed to some of these issues and to make a presentation. Would you have the other certificate? Is there a certificate for Anne?
Yes,
Tatuma?
coming shortly. It's going to be there. It's going to be rejected.
Yeah. And thank you so much. I'm sure you'll be receiving your certificate of recognition. Let's help create this bond between the Busoga Health Forum and Kyabirwa, but also take services to the people. And you can give your closing take-home message. And
Yes.
we call this a good evening for you guys. Me, I'm in Boston, and it is 1:20, so I have one afternoon to go. But coming home for the wedding, I'll be home very soon. Thank you. Yeah, and thank you for accepting to be involved in the Chawazinga medical camp that is coming. Members, we have a medical camp that will start on Wednesday, run Thursday, Friday at Ugembe, and one of the major providers is this Kyabirwa. But also invite you who would like to help in one or another, or to come and provide a service or volunteer, to reach out the CEO of Busoga Health Forum or to Dr. Yai in the Ginger Hospital. Anna, over to you.
Thank you very much, Professor Peter. I appreciate. Thank you, Benjamin, for the opportunity. I really appreciate Busoga Health Forum. I think you've done a good job in putting us together. We'll be working independently, but right now, because of the consortium, we work with everybody. We work with hospice. We work with all the members. We know how to reach each other, and I think this is a platform whose contribution we can't undermine. So we thank you very much for that. As Kyabirwa, we are dedicated to working with you and to help avert surgical dilemma. And so we hope that we'll continue with this very beautiful relationship. We have a lot coming up. We have a lot of expectations. I think Busoga is really blessed to be a recipient of this charitable arm from Mount Sinai. It could have been any part of the world, but to choose Busoga and to come and give it their best, I think we are all blessed to benefit from this. So we'll continue working together. I'm open for more ideas and communication that can help us better what we do. And I look forward to continuing with a healthy relationship with the forum. Thank you very much.
Thank you, and your certificate is here. And thank you so much. Have a good weekend. Bye-bye.
Thank you. Bye-bye.
Excellent. Thank you.
Thank you, Samuel. Very appreciate.
Thank you.
Welcome. Thank you very much.
Thank you.
Thank you, Brian, for the support.
Thank you.
And all members, we are preparing for the health camp for Kyabirwa. I think we will be joining us. So we have our last meeting in Bugembe on Monday at 2 p.m. So whoever is able can join us to plan for. And we have a TV show on Sunday. The technical team for this health camp will be giving the plans and the engagement on Baba TV at 7 p.m. on Sunday. Thank you so much.